internal medicine. You know, this is the formal introduction. So today I'm gonna discuss one of the very important, I think, hematological entity. HIT. All of us have heard this name, thrombocytopenia. I felt like I need to. First, I want to put this number, which is one of the important numbers. So, mortality. What do you think the mortality rate of HIT is? Anybody?
20%.
Yes. So it's about 20 to 30%. And the reason why I started with this number, because this is kind of, for me, was unexpected. It's an average 25%. So I think it's worth kind of discussing HIT, having said that. So the epidemiology went through a very unique trend, and that's why I would like to start with the epidemiology. So when HIT described in the past, maybe 1970s, and now that, changed a lot. So at the beginning, there was kind of more common cases of HIT, and at that point, it was first described, maybe even before, in 70s, but it was first described at that time, and it was very common, and that was because of low awareness, and it was kind of a new syndrome. There was more use of heparin, and there was more procedures, especially aggressive cardiovascular procedures. As we move in years, so the awareness increased and the incidence decreased. Now, HIT, it's not very common disease. I shouldn't say rare, but it's not very common because of less use of heparin. Even, if you use heparin, we try to minimize the number of days people usually on heparin. And the other thing is that we switch from the kind of open heart surgery to more like TAVR and these more minimally invasive procedures. So that being said, let us go to one important, I think, part of our lecture, which is the pathophysiology of HIT. So I would like now to break the name. So the name is heparin induced thrombocytopenia. So if you analyze the name and try to explain the pathophysiology, so the clinical context, usually a patient has to use heparin. So if there is no history of use of heparin, there should be no mention of HIT. So heparin, high molecular weight heparin, more common than low molecular weight heparin, but both of them can cause HIT. So high molecular weight heparin usually 10 times more commonly leading to HIT than low molecular weight heparin. One important thing that I should mention, heparin in the flush, the flushing the lines is very important source and cause of HIT. So if you use heparin, so the second part of the name is induced. That means there is kind of pathophysiology behind this. So we need to use heparin for some time, which is from 5 to 10 days, as we all know. So one important thing. So I want to ask another question regarding heparin. Is heparin antigen? Or I should say, what's the definition of antigen? So, anybody? What's the definition of antigen?
Biologically active substance that gets.
Yeah, exactly. So, antigen is a substance that's capable of inducing immune response. Heparin is not an antigen. Heparin is hapten. And the hapten is a substance that needs to combine with a protein in order to act like an antigen. and that's the case with heparin. So what happened is when you use heparin is meant to be used as so let's say this is the blood vessel. So we use heparin as an anticoagulant, and the main mechanism of action is the stimulation of antithrombin 3. And this antithrombin 3 usually will lead to inhibition of thrombin. And we know that inhibition of thrombin is gonna inhibit fibrin formation, and that's the mechanism of anticoagulation. So that's the main things. But we know that there is a platelets circulating around, which is the primary hemostasis. When heparin gets into the body, so this is the main mechanism, but sometimes heparin can bind to something called platelet factor 4. And this is a glycoprotein on the surface of platelet, which converts heparin from hapten to antigen. And at that point, when this combination happen, there will be induction of immune response. And this immune response usually leads to production of immunoglobulin G. Now, I want to stop at this point and try to reflect on clinical things. So for the formation of these antibodies, you need for HIT to develop, you need from 5 to 15 days. But some people still might have HIT from the first day of using heparin because they used heparin the last 100 days or 3 months. So if there's history of use of heparin in the previous 3 months, you might consider HIT from the first day. And this is one important point. And outside the window, which is more than 14 days, up to 50 days, people still might have HIT. And again, why I mention this, because you might give patient heparin in hospital and send him home, and they come back because they have HIT and they presented with deep vein thrombosis, as I will mention. And usually we use anticoagulation, and we use heparin at that point, and that would be kind of fatal. So late HIT can happen, early HIT can happen, but classically it's from 5 to 15 days. The other point is there is IgG but no IgM in the pathophysiology. And the reason why I mention this, if there is no IgM, that means there is no immunological memory with HIT. So one can ask you, a patient or whatever, can I use heparin if patient had HIT, history of HIT? The answer may be yes. Why? Because this IgG tends to fade and disappear after an average 100 days, which is more than 3 months. So after 3 months, you can remeasure the IgG, as I will describe shortly, and then you can consider and discuss reintroducing heparin if needed in surgery or whatever procedures, because there is no IgM and there is no immunological memory. And again, this is very important fact, and it does affect our clinical practice. Right, so when heparin combines with the platelet factor 4 and IgG formed, there will be kind of immune reaction. And what the antibody usually do, antibody either block, either inhibit, either activate. And these antibodies are activating antibodies. So they bind to the platelet and they activate the platelet. And they lead to kind of platelets aggregation. And that will count to 2 important parts of our definition or clinical criteria of HIT. The thrombocytopenia, so there is low platelets, and that's why we define HIT as reduction, 50% reduction from the baseline, as what I will describe shortly. So it came from that kind of pathophysiology. The second thing, it seems like counterintuitive that patient has thrombocytopenia, but yet he is high risk of thrombosis. At that point, now I can kind of explain that by platelet aggregation that will stimulate, the cascade that we know of thrombogenesis. And that's why one of the criteria in HIT is the thrombosis, and the most common site of thrombosis is deep vein thrombosis. People usually have PE, and this is the source of mortality, and this is the reason why people usually die. It's usually the thromboembolism. It can be arterial, and it can be even venous thromboembolism. So having said that, we usually investigate HIT by trying to measure the IgG. So we have two types of assays, what's known as functional assays and immunoassays. So the immunoassays is the ELISA, the famous test. So we usually try to assess if there is any IgG in the patient serum, and this will be described shortly. And the other thing is called functional test, which is the platelet aggregation, the famous, the very specific, but yet it's more complicated test, which is the serotonin release assay, which is the SRA. So serotonin release assay is the rationale is combination of patient serum with the normal platelets with heparin, and if patient has aggregation or the platelet has been more platelet aggregation, that means it's a positive test. So this is more specific test, and we'll describe later. So this is the pathophysiology of HIT. One last thing, we usually treat HIT. How we usually treat HIT? Needless to say, we need to stop heparin, but at the same time, we need to inhibit the coagulation at thrombin point, because warfarin is contraindicated, heparin, high molecular weight, low molecular weight, both are contraindicated. So we have medications, the direct thrombin inhibitor, like argatroban, like others that I will mention. So this is the main management. Right. So after the pathophysiology, so how we diagnose HIT. So we have this score, which is, we call it 4T score. This score, if the component is the pathophysiology, so thrombocytopenia, and they said more than 50% fall, and nadir more than 20. The lowest platelet usually in HIT is not that severe, so it's usually more than 20,000. But one thing I wanted just to emphasize at that point, if patient started from a baseline of 400 platelets, 400,000, and then after 5 days or 6 days, the platelet becomes 200 or 150. So that criterion, although the patient platelet is still more or less around the lower limit of normal, but this considered a criteria for HIT. So you can still diagnose HIT even with a platelet with 200,000. But this platelet is eventually gonna be low, maybe in a couple of days, because this is kind of dynamic process. But my point is the 50%, that doesn't mean we need to have absolute low platelet count. And this is very important to mention. Timing, I mentioned 5 to 10 days, but it still can happen after 5 days, even after discharge, and it still can happen before 5 days if there is a previous exposure to heparin. Third important is thrombosis. And thrombosis mainly confirmed, or maybe worsening, or no thrombosis according to classification. The fourth thing is other causes. So for example, if a patient is known case of ITP, or a patient has DIC or infection, and the clinical context is explainable by other causes of thrombocytopenia, again, that might be important. So every one of these four, you can give 0, 1 to 2 points, and then at the end, you will classify the patient as low probability, moderate, or high probability. So 0 to 3 is the low probability. And this score has, very high, it can negative predictive value. It can exclude if it is low. On the other hand, you can't exclude HIT in moderate and high. So what you will do is that, so usually we approach this score like that. If patient low probability, I know that it has very high negative predictive value and it can rule out HIT, but one important thing is if the clinical context is still going with HIT, I will go for testing rather than just say, and I might consider stopping heparin and actively manage the patient. You can argue at this point that it is not HIT, but if it is moderate to high, that means you have to take the actions that I will mention. You have to stop heparin, you have to send the investigations, and you have to start actively treating patient like a HIT, unless excluded later. So this is so what you are going to do based on medium or moderate or high probability. The thing that you are going to do is to test the patient and to take actions. One mistake usually I should warn of this mistake. This is some people just carry on with heparin. They usually treat the patient the same and they wait for the serology or the investigation, and this shouldn't be the case. So you send the blood test, but you take the action and treat like a HIT. Now the diagnosis or the test that you need to do is either the simple one, which is the ELISA, which is the immunoassay, or it could be the functional test. The most famous is the serotonin release assay. So ELISA has high sensitivity and it can exclude, but it can't prove. And serotonin release assay, it's very highly specific, but it's not readily available and it's a complex test. You might not have access to this test every time. So the more commonly used is the ELISA because it's readily available. Now, how can you explain ELISA? Because serotonin, it's easy to explain. If it is positive, it has high specificity for the HIT. So ELISA, usually the lab result of ELISA in HIT usually come like a positive or negative result. And that's very important and tricky. I have discussed this with one of the hematologists. And positive means any value above 0.4. Sorry for that. Positive means any value more than 0.4. And negative is any value less than 0.4. So this is positive. All of these are classified as positive. And more than 2, again, is still positive. Now, if it is negative, that's negative. But if it come positive, can you see this, which is HIT likelihood? So with less than 0.4, the likelihood is 0. Okay, so it has good sensitivity, so it's ELISA is able to exclude HIT. But it's positive in 0.4 till 2. From 0.4 to 2, it's positive, right? And you can see it's 2.7. That means at this point that I am describing, 97% of people are negative. Because this is around 3%, only positive. And that means we need the optical density range. This is the optical density. We need a numerical value. If you say, for example, ELISA is positive and it is more than 2, that means it's about 90% of patients do have likelihood of HIT. So my point is, if it is negative, it is negative. But if it is positive and more than 2, this is highly suggestive and very sensitive for HIT. But if it is positive and it's from 0.4 to 2, that doesn't mean HIT. One thing, does the lab send us a numerical optical density? The answer, not. When I discussed this with one of the hematologists, especially lab hematologists, they said, we know that's important, but there is no, it's not approved in the guideline to give this number. So we are obligated to give it like positive and negative, and we are happy to call and discuss. So I think at this point, if you have ELISA, I think it's worth kind of discussing the result if it is more than 2, so that's very highly sensitive. If it is negative, no need to discuss, but if it's from 0.4 to 2, you need just to call for optical density number and they will give it to you, right? This is very important in using ELISA. Serotonin release assay, yeah.
So this is important because if it's in the gray zone, basically, we don't act on it unless it's over 2.
Act on HIT, you mean?
Like treat it, yeah.
Right. So the treatment, the decision of treat or not to treat HIT is based on the likelihood and the 4T scores.
Okay.
So if you have the 4T score, can you see the investigation, the ELISA is not included in there. So if it is...
So this is more confirmatory.
Right, exactly.
I see.
So you act and treat if
On
it
this
is moderate to
score.
high,
Okay.
and at the same time send this.
Okay.
And this has medico-legal, again, implications,
Yeah.
because there are many doctors being sued because of not treating probable HIT. And this is why the trend in epidemiology, it was less commonly tested for HIT, and now it's rare, uncommon, but there's more testing. And that's because of that medico-legal aspect. So you have to do this test, but the actions is based on our score.
Okay.
Any question at this point? Right. So these are the actions that you will take if you find your patient intermediate to high probability. But again, you should think of these actions if the patient is low probability with the clinical context which is going with HIT. First, you have to discontinue heparin. Again, we all agree about that. Give a non-heparin alternative that I will shortly describe in the next slide, like argatroban and direct thrombin inhibitor. And the third, postpone warfarin pending. Again, the substantial platelet recovery. The point here, do we still use warfarin? So the message regarding the warfarin, number 1, don't use warfarin. We all know that. Number 2, if you are considering to reintroduce warfarin because of long-term anticoagulation, reintroduce warfarin after recovery of platelet count and you treated patient. Usually, mostly more than 100, but if you want to play it safely, usually more than 150 platelet count. At that point, you can reintroduce warfarin, and that's okay. But in early diagnosis of HIT, you shouldn't start warfarin. And if patient is already on warfarin, you need to reverse warfarin. You need to give vitamin K to reverse the action of warfarin, and I will mention the reason later. But one of the things that warfarin do, it might interfere with the interpretation of argatroban, because argatroban that we're going to use as direct thrombin inhibitor affect the INR. And at that point, you don't know the INR was because of warfarin or because of argatroban, and you want to titrate the argatroban. So at that point, you need to reverse. This is one reason. The second reason, if patient is not in warfarin and you started warfarin, so the mechanism of warfarin is inhibition of factors like factor 2 and factor 7 and factor 9 and factor 10. These are the vitamin K dependent factor. But at the same time, it inhibits protein C and protein S, which are, these are anticoagulant and these are procoagulant. So warfarin, initially, especially if you started like more than 5 milligram, so usually you inhibit both things. So initially, this one have shorter T-half or half-life, and this one has longer half-life. So if you kind of compare, at certain point, I blocked all of these. So these will disappear from the blood first because of short half-life. And meanwhile, for some time, you will have procoagulant effect. And that's the rationale why warfarin is an important cause of skin necrosis and, the blue toe syndrome, why initiating warfarin, even sometimes without background of HIT. people sometimes develop this side effect from warfarin because of using a relatively higher dose, and warfarin will block both of them, and you have certain amount of window before having the INR kind of prolonged and the therapeutic effect, and these are active and unopposed. And at that point, a patient will develop the necrosis. And this pathophysiology is gonna be more exaggerated in HIT. That's why warfarin shouldn't be started, and you restart it after recovery of platelets, and for the other reason that it might make interpretation of argatroban titration difficult.
I have a question.
Yeah.
You said, so it's okay to restart heparin after 100 days of...
You can discuss that, yeah.
We can discuss it. And we can restart warfarin after recovery of platelets. Is there also a time?
For warfarin,
Yeah.
we have a number. We have 150. I will. The numbers there. So the platelets recovery, definition of recovery, that the platelet start going up. So we are not giving platelet, as I will mention, but if the platelets, for example, was 80, and then you stop everything, you start the management, argatroban, and the platelet number start increasing, and then 150, patient has no thrombosis, nothing. So at that point, you can discuss reintroducing warfarin. The reason why you think about warfarin, because the patient at this point, which is short time, you can't restart heparin, low molecular or high molecular, and it's non-practical to use argatroban, which is high risk of bleeding. And at the same time, the new factor 10 inhibitor like rivaroxaban, and they are not well studied in HIT. So you don't have many choice. So at that point, you will consider warfarin. So the other point is, test for HIT, as we mentioned. So these are the actions that you will take if the patient has moderate to high probability. Investigate for lower limb deep vein thrombosis. And I have a question at this point. If a patient has no thrombosis, does that exclude HIT? Right, yeah, so it doesn't, okay? So there is HIT without thrombosis. So thrombosis is just part of the score, okay? So you still might have medium to high risk with that. But this is a common, site of thrombosis. Avoid prophylactic platelet transfusion. If you give platelet, you are actually perpetuating the pathophysiology. You are kind of giving more platelet, and the antibodies are activating, and you are kind of, it's like the concept of TTP and HUS, the hemolytic uremic syndrome. It's more or less the same. Platelets are activated and consumed, and you are giving a platelet, so are you keeping the cycle. So platelet is contraindicated in that perspective. So after discussion of pathophysiology, diagnosis, and now we already discussed the treatment, and we did mention that you start this. Stop heparin, do the things that we discussed about, and now you use the direct thrombin inhibitor. So the only approved in the US is argatroban and bivalirudin. These are the only approved. There are another approved in the UK, okay? So for argatroban, it's direct thrombin inhibitor. It's FDA approved. It's given IV infusion. It's cleared by liver, so you shouldn't worry in renal impairment. And the good thing about it is the short half-life. So again, this is considered as an advantage. So, you can titrate because of the short half-life. So as I mentioned, it's usually affecting INR. And the fact that it affects INR, that's the reason, one of the reasons why we need to reverse warfarin if patient is already on warfarin and developed HIT, because that's gonna affect our titration to argatroban, and that will lead to maybe bleeding, because argatroban is considered higher risk of bleeding than the other anticoagulant. So this is very important. We monitor APTT, and the target for argatroban is APTT 1.5 to 2 upper limit of normal. but at the same time, it affects the INR. We usually monitor the APTT, and our goal is the APTT 1.5 to 2. But at the same time, the INR is going to be affected, and we don't know is it from warfarin or from ergotamine. Bivalirudin is again dithrombin inhibitor. This is again approved in the US, and it's usually for PCI. So it's more of cardiology procedures, okay? But it can be ergotamine or bivalirudin. Again, we monitor APTT and the clearance with non-specific proteases, which is hydrolysis in the plasma. One last thing regarding the drugs that we can use, fondaparinux. Fondaparinux is not approved by FDA, but fondaparinux can still be used, especially in pregnant female with HIT. Back in, when I was in the UK, so they use one of the medication called danaparoid. This is very specific medication in HIT in pregnancy. But this is not approved in the US. Danaparoid is not approved in the US. So fondaparinux is not approved generally, but experts consider usually using this in pregnant female because it can't cross placenta. The other two, it's difficult to use because they can affect the baby and they can cross placenta. So fondaparinux, FDA approved for VTE prevention, but not approved for HIT. And again, the dose in HIT is not clear. So, doesn't need any monitoring of factor 10. It acts by, factor 10 inhibition. So, this is the danaparoid that I mentioned. This is in the UK, which is combination of heparin, low molecular weight, dermatan sulfate, and chondroitin sulfate. Fondaparinux, again, I already discussed. Liperidone, this was used in Europe and was used in the UK, and now it's no more used. Again, avoid platelets. Warfarin will worsen skin necrosis. Only consider sense platelet more than 150. This answers your question, Hind. Avoid reintroduction of heparin for 100 days to minimize the risk of thrombosis. If somebody just kind of read this statement without understanding the pathophysiology, he might ask the idea behind this. And again, they mentioned there is no IgM antibodies produced, no memory. So you can, if a patient, for example, desperately needs heparin in this window, and you can discuss that, and you can test again. And again, this is another important use of ELISA. You can use it now to test for negativity. If it is, because the optical density give you quantification, you can, if there is no antibodies, and maybe even before 100 days, you can reintroduce it and discuss that with the hematologist. So this is our discussion. So that's it. The take-home message. It can happen before. One second, Mohammed. It can happen less than 5 days. It can happen more than 10 days. My most important message for today is that if patient used heparin in hospital and has been discharged maybe 2 to 3 weeks and came back with DVT, so you should think about HIT, because at that point you will consider using anticoagulation, either heparin, low molecular weight, and if it turned to be HIT, that would be catastrophic and the patient literally will die. This is, deadly disease. That's the big take-home message. Answer your question, ma'am.
Does getting HIT predict future chance of developing another HIT if you use heparin after the 100 days?
So that's a very good question. One important group of population of people is hemodialysis people. Usually hemodialysis people have HIT antibodies. You can, if you do the ELISA, you will find it positive, but they don't have symptom of HIT. So these antibodies can be non-pathological in some populations. And answering your question, If some people, they might have the antibody and they don't have that, complete clinical syndrome, I don't have kind of direct answer, but I think that would increase the future risk, but that should not preclude the use of heparin. So one of the things that will be documented in the patient allergy, and for example in EPIC, you will document heparin allergy and high risk and HIT. And at that point, after 100 days, I don't know if we should remove this or not. Again, this is something I think we should discuss with more senior person.
So I had a question kind of going off of Hin's in terms of starting the warfarin. What if the platelets are already at or above 150 when you start treatment?
Right. So again, good question. So if the platelet more than so what I wanted to emphasize at the beginning of my talk regarding the platelet count is that at the diagnosis of HIT, the platelet count can be higher than 150, but eventually it's gonna go down.
So it's going to continuously go down despite
Exactly, because it is a dynamic thing. But at the time of diagnosis, when you are considering that, some hematologists argue that this should be absolute number less than 100. So at that point, if some hematologists argue this, that means they need it like absolute in order to consider. Some of the hematologists I discussed with him this one, his opinion was, I don't agree about diagnosing HIT with a number more than 150. That's one of the hematologists' opinion. I never consider HIT with that number. But given the fact that it will kind of trend down in the coming days, that's the thing. So just for the sake of early diagnosis and early action.
And then kind of on top of that, is there a bridge for the warfarin that you have to use? Or
For what?
when you restart the warfarin, typically we bridge warfarin with like Lovenox or whatever, right?
Right.
But what do you use? Do you use like the...
So I have no experience of this, but argatroban is gonna mess with your INR. I don't think this is the bridging medication. Maybe bivalirudine, maybe that's alternative, but I have no clear answer for this. I would consult, hematology about the bridging, because this is.
I remember we had a patient who, I can't remember why, but we couldn't use heparin, and he was on an argatroban drug.
For bridging?
For bridging to warfarin.
Typically, you look at to have a certain INR to stop the bridging, right?
Yeah.
But then if argatroban messes with INR, then
Yeah.
it's not accurate.
So pharmacy, they gave us I think an INR of 2.5, and then at that point you would discontinue the drip, and then you would remeasure it in 4 hours, I think,
Yeah.
which theoretically
Yeah,
your
yeah.
argatroban should
Makes sense.
may,
Yeah.
disappear from the system, and then that INR is still above 2, then you consider.
That makes sense. Yeah. Right.
I have two questions. The first one is for how long we treat with argatroban, and the second question is again back to the INR. So given vitamin K, you will not see a result of immediate reversal of the INR. So does this affect you starting dose of argatroban?
Yeah. So for the first question, so you asked about the warfarin. What's your first question? Okay, the recovery, the criteria for recovery. So the criteria for recovery is that platelet count back to normal. That's the thing, right? We're not treating thrombosis. Thrombosis is gonna take time. So platelet count is gonna kind of so the guidelines usually says from the 4th day you need to measure platelets every other day for diagnosis, and then when you start treatment, you usually, for example, if the platelet count is going down, that means there's no response. But if the platelet count is going up and recovering, so recovery of platelet count more than 150, I think this is the most important thing. The second thing is that the effect of vitamin K is not gonna show up kind of early. You don't have any other kind of sort of theoretically you are reversing warfarin. But in that window, you are already using the argatroban or using, so it still covers, but we don't want, like I said, the second reason now will remains valid for the argatroban. Yeah.
Thank you.
Any question? Right. Thank you so much, guys. Thanks.
Yeah, that was great.